Is there any comparative study head-to-head between sitagliptin and other gliptins?
These are very kind of small trials which are coming in. But as of now, the head-to-head, there's one important, this I might show to you. This is also for the company guys, whether I don't know, this is Sheen's paper. DPP-4 inhibitors in the management of type 2 diabetes, a critical review of head-to-head trials. So you can go through this, and you have all the gliptins here. Lina, Algo, everything is there. And this is a recent publication. This guy is from Belgium. We communicate on the mail. So this is head-to-head. And from this head-to-head, what we have derived is Saxa is very safe and very sound. Other questions? Practical questions. Daily, daily encounters, daily, the fear that we have as physicians when we, face the patients. It's not always the patients who come, very nervous. We also are very nervous with seeing some, numbers. We grope in the darkness of knowledge to find out what to deliver, how to deliver. Yes?
I am a ENT surgeon here. I have got one patient in my ward. He came with sudden sensory neural hearing loss and a known case of diabetes mellitus with nephropathy. End stage renal chronic kidney disease stage 5. And right now his CVS is around 700 something. Person is saying. So how to manage that? He is on insulin.
Obviously insulin. Because he's an indoor managed case, he should be on a very well designed protocol of insulin management. He should be on a basal bolus therapy. If his body weight is 60, then 30, 50%. I mean, we go by 0.1 milligram per kg or unit per kg. So we will choose 30 units basal for him and 30 units prandial. Prandial is before breakfast, before lunch, and before dinner. And we will choose exactly what is his carbohydrate count at breakfast, at lunch, at dinner. And then we will divide that 30 into 10, or say perhaps 10, 12, 8, that kind of stuff. This is the first starting dose. And we have to keep a very, very strict vigil on the sugar counts. This kind of patient can have a vascular compromise, a sudden vascular compromise in the, in the vessels supplying the auditory nerve. So these are more of vascular auditory deafness. The patients who have, for ENT and diabetes, rhinocerebral mucormycosis, very, very rare. But these are the events one has to really think about whether there's certain infection also with it. So for that, your sugar has to be brought down below 200. If you say the average sugar in a day. And you have to target it if the patient is in the ICU, not below 140. If the patient is in the ward, you can also target it to around 110. Because ward, if you precipitate hypoglycemia, we see the chances of death going up. But if it's just casually managed in the ward, then you target around, around fasting is around 110, and the PP within 200.
Patient is already getting insulin around 30, something like that.
Wow. No, 30, something like that is a sliding scale. Sliding scale is completely out of vogue from, the international guidelines. It is still there in our country. The problem is you will not get a clear cut, good control. You will once see it's coming down to 80, then you will see it's 225 because you don't have a basal. If you had kept him on a basal, his total average sugar cannot go up. And for we always say that fix the fasting first. Fix the fasting first. FFF. How do you fix the fasting? It's when you do it with the basal. Basal is that minimum amount of insulin which is required to supply and perfuse, to take care of the glucose to certain level, and which glucose will actually perfuse all the vital organs to keep you going. And while doing it, it brings down the lowest glucose earliest, and which is the fasting glucose. And basal cannot actually take care of the postprandial surges. So for the postprandial surges, if you want to mimic physiology, the best you can do is if you have the option of writing analogs, the analog mix, say, I name them, Humalog 50-50 or Novomix 50-50, you give them for breakfast. Or Novomix or Humalog for lunch. And then 25-75, a little long drawn for dinner. Or if the patient is not having a very substantial, meal, then we cut it to only one, just a rapid acting analog. So these are the things that you can do in order to get that control. But you have to also work that, calculation in your mind. You have to also see that, first you have to see that to believe that this happens. So you have to see certain cases that this is happening or read up. And once you've done that, then you exercise or implement that on your patient and do that for 2-3 days, again to see, to believe that this is the right method and not 30-30-30. 30 will only take care of that patient in next 4 to 6 hours. But again, by that time, the patient will have some other meal and, in 2 hours time it will shoot. And if you're giving an analog, that's the best method, but how many people can afford to pay for an analog? So for this kind of a patient, must give a basal and then give that 30-30 or 10-10.
One more question, should I stop the steroid work which I am giving because this...
No, steroid is something that you need to give to your patient. That's not the patient asked from you. So you are the best judge whether this steroid was necessary. Now if the patient will have the merit, if you weigh for the pros and cons and weigh for the merit and the demerit of the case. If you want to actually reduce the edema of that nerve or whatever, then you need to give him steroids. And if you give him steroids, then your basal has to go up to from 0.1, actually it's from 1 to 1.5, if not 2. So these are the calculations which you can read up. These are all on the net also. Patient, what is the guideline of insulin therapy in a patient having steroids? Categorically. Actually, the chapter is written by, this chapter calls, it's like management of hyperglycemia in hospitalized patients. This is the chapter, a 47 pages paper. Absolutely fantastic review. Everyone should read. If you're not treating diabetes, you're not treating an Indian today. So these are the basic preliminary things that you need to just read up. Then you have your medicine friends to take care. You've got your critical care, these people who do it. The anesthetists, they manage glycemia on the table. Absolutely, that's on their fingertip. So, they are not actually endocrinologists, but seeing this, doing this every day, day in and out, they did this. So you'll be able to do it. A lot of checks are being written. Looks like a very rich place. Yeah, yes.
Very knowledgeable place.
Usually with the diabetes, patients are obese and some of them are suffering from this non-alcoholic fatty liver disease. And in case of non-alcoholic fatty liver disease, we use either metformin or glitazones. They have some effect. Particularly, they will reduce the disease progression, or there will be some improvement of the ASTs and all histological pictures. So my question is whether the DPP-4 inhibitors have the same effect. Is there any papers? Number one. This is number one question.
Actually, my cousin passed away at 5 o'clock.
Oh.
So they're taking him to the burning heart and they want.
Oh, so
my
sorry.
wife hasn't reached. So
Okay.
না আপনি করুন আমি ঘরে যাচ্ছি আমার স্ত্রী চলে গেছে ওদের ওই গাড়িটা নিয়ে চলে গেছে তো এটা কল করেছে তুমি মামু তুমি আসছো কিনা আমি এখন আসি
Another second question. This DP4, these are the substrates of some of the important, particularly the neuropeptides, substance B, and some cytokines. So if we block the DPP4, is there any negative effect in our body? These are the questions.
বসে বসেই বলি
বসে বসে কোনো হাইপোগ্লাইসেমিয়া
আমি তো হচ্ছে এখানে সকালে ওকে বললাম চা খাওয়া চাটাও যদি আছে
So, the answer to the first question is that, metformin, glitazones. Glitazones though had, pioglitazone had a paper showing that it brings down the markers of necrosis in case of a NASH going into full-fledged chronic liver disease or cirrhosis. So those the steatotic fragments, all these changes are seen. The microvascular Kupffer cells, these are all observed, right? In DPP4 inhibitor, what we do is we augment GLP-1 mechanism. Now, GLP-1 is the glucagon-like peptide, which actually helps to secrete insulin once you're having some glucose. We're coming to very basics. And that's why incretin is so named. Incretin is named because intestinal secretion of insulin, right? Now, once you give a DPP4I, you augment the GLP-1. Normally, a GLP-1 lasts for 1 to 2 minutes. But if you don't have DPP4, ubiquitous DPP4, ubiquitous in the sense it is released from almost all structures of the body. And if you can stop that DPP4, cleaving that GLP-1, the active GLP-1 at site, the amino acid site sequence 7 and 8 between that, then you get that active GLP-1 surviving for some good period of time. What this GLP-1 does is GLP-1 has a fantastic property, specifically chosen for liver. It has a glycogen synthesis activity. So, as an insulin-sensitive molecule, where the glucose transporter will take up the glucose in the liver tissue, they will quickly convert that into glycogen synthase or into glycogen with glycogen synthase. While doing so, because of this activity, the Kupffer cells are also charged and active. So the steatosis part is a resting part. Get a lot of supply, or they have to kind of shove and make space for the glycogen. So in that context, today GLP-1 or the native GLP, nascent GLP-1 is being thought to take care of NASH as a whole. Question number two, whether DPP4 is only DPP4 that the inhibitor targets, or whether the DPP8, DPP9, these are the other dipeptidyl peptidase. This dipeptidyl peptidase, what they do is you need to have them because they degrade certain toxic, byproducts of our body. Like he said about neuropeptides, talked about substance, substance P, the neuropeptide YY. So these are a lot of the angiourea markers are there. So these are actually the slow-release substrates which are secreted from the body. And once you stop these substrates, they will actively cause perhaps an angioedema, and you will die of an angioedema. But the best thing is that these molecules obviously are being tried to basically work as only DPP4 specific and much less kind of affinity towards the other variants, or DPP8, 9, 12, 16. So therefore, the latter ones, the gliptins which are coming later, obviously are researched well and more extensively. And Saxa also is a very, very specific, DPP4 specific inhibitor. So it is not supposed to, because there has not been any paper till date on any major adverse reaction.
But sitagliptin has some angiolytic edema. There were some papers.
There was, Wilda had some skin rash, but that was in animal models. These were all in animal models.
What is the frequency of this UTI in this particular case?
UTI is 6.7 as on all complete review research. They said 6.9, vis-a-vis 6.1 with placebo. And nasopharyngitis is, nasopharyngitis is 7.3 versus 6.1, and this is 6.4 versus 5.8. Yes.
Good afternoon, sir. Is metformin safe in liver disease? Like we have cases of alcoholic liver disease with type 2 diabetes. So can we give a metformin in such patients? And also saxagliptin.
Yeah, I mean, hepatic impairment wise, obviously liver doesn't have any problem. Metformin. But Saxa, we would try to restrict if the
the SGPT, the baseline SGPT is more than 3 times, then we'll wait. That's how the paper recommends. And in fact, in NASH, you hardly get above 100 SGPT. You get within 100. So if it's 35 or 37, then it's within. So you can jolly well start it, and you will not see any change. We have done in so many cases. Metformin, you merely give around, but you don't think about only creatinine 1.4 in females, creatinine 1.5 in males. I'm very skeptical, very cynical. There are good doctors, good friends of ours, who still go above 2. Papers coming in saying that this renal compromise is not worrisome, but I still, I'm very conventional. I stop metformin when the creatinine is more than 1.5 in males. But if there's no kind of cutoff for SGPT in administering